They don't know.
They don't know. In women, in 50% of cases, the ulcer appears on the pudendum. Okay? Whereas that means on the external genitalia. The other 50%, it occurs along the inner vaginal walls, so you don't see it. And because it's painless, they don't know it's there. So it goes untreated. Now, after a couple of weeks, whether it's treated or not, the ulcers tend to go away. I say ulcer, it's the ulcer tends to go away. Does that mean that the syphilis goes away? No, it's still within the bloodstream. So for those women who went untreated, maybe a month or two later, they'll present with signs and symptoms of secondary syphilis. Oftentimes, a common manifestation of secondary syphilis is a rash that can look a lot like other rashes. So when that patient develops the rash, they have no idea that they had primary syphilis. They present to their primary care provider and they say, I have this rash. And like most patients wanting to help, they'll say something like, well, you know, I was working in my garden this past weekend. I may have come in contact with some poison ivy, thinking that they're helping. And a primary care physician who's not a specialist in skin diseases, he's going to give what he's trained to do for a rash. You typically give Benadryl for itching, and you give a steroid cream. Okay? And he'll say, listen, if the rash doesn't go away within a week or two, come back and see me. Okay? With the idea being that then I'll send you to a dermatologist. Well, the medication that he gives will provide some symptomatic relief, and in fact, the rash eventually goes away. But did the syphilis go away?
No.
No, because she wasn't treated with an antibiotic. And so then, over the course of maybe 10 years or 20 years, the organism is percolating within the bloodstream. It's beginning to infect other tissues. And so that maybe 10 or 20 years later, she presents with signs and symptoms of tertiary syphilis. Now, tertiary syphilis can present in a number of ways. For instance, early onset dementia can be due to tertiary syphilis. So for that reason, anyone who presents with dementia under the age of 60 is going to undergo a serologic test for syphilis. Okay. Tertiary syphilis can invade the wall of large blood vessels like the aorta and result in aneurysm formation. You know what an aneurysm is? It's a ballooning. And so when someone presents, particularly with a thoracic aortic aneurysm, they're going to undergo a serologic test for syphilis. Tertiary syphilis can involve the posterior white columns of the spinal cord. Remember the spinal cord looks like this? Okay. These are the posterior white columns here. These posterior white columns carry ascending tracts, particularly for vibration and proprioception. Okay, proprioception is the key word here. Proprioception is the knowledge of how our limbs are positioned in space without having to look. Okay, it allows us to stand straight up without looking down where our feet are. Okay, it allows us to walk without necessarily looking at the ground. So people who develop involvement of these posterior columns, this condition is called Tabes dorsalis. Tabes, T-A-B-E-S, dorsalis. These people lose position sense. Okay? So what happens is, if you have them do what's called a Romberg test, where they stand straight with their arms at their side and then close their eyes, losing visual cues, they tend to lose their balance. When they walk, what they do is assume a wide base gait, because their gait tends to be somewhat unstable, and a wide base gait is more stable. So they're like a toddler who's first learning. You know how a toddler assumes a wide base gait because it's a more stable gait, it's an easier one to remain upright with? So that's how these people with tertiary syphilis do. And they don't pick their feet up off the ground, so they can constantly feel the ground. So if you ever see Sanford and Son, the old man,
Yeah.
okay, he looks like he's got the gait of someone with tertiary syphilis, with Tabes dorsalis. Okay, if you ever pass like Camp Street, where the or if you go to North Rainbow where there's a food kitchen, you see a lot of people who are homeless. They have tertiary syphilis. You just look the way they walk. Okay. So.
What happens by then? It's too late.
Yeah. Well, what you can do is you can treat at any stage. The problem is when you treat at tertiary syphilis at that stage, you prevent further progression, but you don't fix the damage that's occurred to that point.
Do some people, like, not knowing that they have it, get prescribed an antibiotic for something else and have it resolve?
That can happen, yeah.
I mean, like, what else? You said you have to give the penicillin G for that?
Well, penicillin G has classically been the drug of choice. Are there other drugs? Rocephin, which is a third-generation cephalosporin. That works by similar mechanism, by the way. All your cephalosporins work by inhibiting cell wall synthesis. Okay. And so Rocephin is also effective. So sometimes you end up getting treated for something else, and it will. But not all antibiotics. If you take, for instance, just amoxicillin, chances are it's not going to cover. Okay. Part of treating syphilis, by the way, if you treat with treatment of syphilis requires low levels of penicillin within the blood for an extended period of time. The beautiful thing about benzathine penicillin is that it doesn't produce high levels, but it produces sustained levels over a month. So that's why it's effective. When you treat other infections like a UTI and you treat for 3 days, is that going to really get syphilis? No, it's not long enough time. But on the other hand, if you have osteomyelitis that you treat for 6 weeks with Rocephin, yeah, that would cover it. So sometimes you can, just by accident, treat it. Okay.
So if you catch it too late, like secondary syphilis, and you get treated, then you can't have children?
No, it's it doesn't necessarily cause infertility. Gonorrhea can.
Right.
You know, gonorrhea can cause inflammation within the fallopian tubes. That can lead to scarring and obstruction. So yeah, gonorrhea, chlamydia, they can cause what's called pelvic inflammatory disease and lead to infertility. That's not the case for syphilis. Gonorrhea, chlamydia, other STDs present in different ways.
They did that in a movie, and I was like, there's no way. Because have you ever watched Out of Africa on Renal Street?
Mm-hmm.
It's really good movie.
Oh, maybe I did a long
With
time ago.
Robert Redford?
Yeah, that was a long time ago.
It's a really good movie. But
somebody had syphilis?
Yeah, her husband was flown around, so when he came home, he gave her syphilis.
So some mistress or somebody.
Yeah. So when she went to the doctor, he told her she could have children after he treated her.
Wait, so Robert Redford got syphilis?
No.
Who got the syphilis?
Her original husband.
Oh, and then she married Robert Redford.
She didn't marry him, but she was with him. He didn't want to get married. He's a free bird.
She was living in sin.
Yeah.
Okay, I got it. All right, it's complicated.
Yeah, it's good. You need to watch it.
Yeah, I did a long time ago.
We'll rewatch it.
I need to, you're right. All right, so let's talk about uric acid. We said that uric acid is the solute within blood that's responsible for gout. Normally a high percentage of uric acid is filtered, but the problem is it gets reabsorbed in the PCT, even when serum levels are high. So you can imagine that for patients who have gout, that's a problem. Okay? Now, the PCT also secretes some uric acid. Okay? It turns out that probenecid, okay, the same drug that inhibits secretion of penicillin, also helps to block reabsorption of uric acid. So now, if you block its reabsorption, then uric acid is filtered and secreted, but not reabsorbed, so that serum levels fall. So many patients who have gout are treated with probenecid and other uricose-uric drugs. Uricose-uric means that these are drugs that trigger excretion of uric acid, preventing serum levels from climbing, preventing uric acid levels from becoming supersaturated where it precipitates out into joints or into the kidneys. So we can use probenecid also for chronic gout or hyperuricemia. let's talk about how diuretics work. Again, pharmaceutical companies use their knowledge of renal physiology to design drugs. Aldosterone antagonist. The classic one, when it's been around forever, is called spironolactone. Its brand name is Aldactone. Now, spironolactone simply works by blocking aldosterone receptors on the DCT and collecting duct. So if spironolactone is sitting on those receptors, it doesn't allow aldosterone to bind. So what does that mean? That means less sodium gets reabsorbed within the DCT and collecting duct. More sodium, therefore, gets excreted. Okay. The fact that you have less sodium getting reabsorbed in the DCT and collecting duct means that you're going to have less water getting reabsorbed. Because when you block sodium reabsorption, that additional sodium within the filtrate holds on to water. It pulls water with it. It creates osmotic pressure. So that then the patient diureses. They spill more salt and water into the bladder. Okay. Spironolactone is referred to as a potassium-sparing diuretic. What does that mean? Well, when we give most diuretics, the patient tends to lose potassium, and so you have to give it with a potassium supplement. Not the case with spironolactone. Because at the same time you're blocking reabsorption of sodium, you're blocking secretion of potassium. So it's one of the few diuretics that you can give without giving supplemental potassium. Okay. All right, here's our Bowman's capsule. Here's our PCT, descending level glucopenylate, ascending level DCT, collecting duct. Okay. Loop diuretics, and there are three major loop diuretics that are used all the time: Lasix, Bumex, and Demodex. Have y'all heard of these? Everyone's heard of Lasix, huh? What's the generic name for Lasix? Furosemide. Furosemide. The other two, so furosemide or Lasix has been around forever. The other two are called Bumex and Demodex. These are all loop diuretics. Loop diuretics result in a brisk diuresis. I always relate the story that my dad used to take my brothers and me to the fairgrounds. We used to watch horse races. And they'd parade the horses in this one little area next to the stands before they brought them to the starting gate. And in this little area, you'd see these horses all peeing. Okay, and I remember that, to me as a kid, I was fascinated by the thickness of the stream and for how long it went on. So I remember asking my dad, I said, "Dad, how much those horses are peeing?" And he looked at me and said, "That's because they give them Lasix." Okay? I didn't know what Lasix was. I just knew at the time, from that like 7 years old, I knew that Lasix was something that makes you pee. Hence the term peeing like a racehorse. Okay? But the way it works is these loop diuretics block the reabsorption of salt that occurs with an ascending limb. And so you present more salt to the distal part of the tubule and then to the collecting duct. Okay? So that high solute load is going to hold on to water. So you have a higher filtrate concentration. Instead of being 200 here, it's going to be 300 or 400. So now, even in the presence of aquaporins, there's no gradient that pulls water out. The sodium, as it comes down the collecting duct, is holding on to water. Okay? So That's the way loop diuretics like Lasix and Bumix and Evenix work. They block the active reabsorption of salt in the ascending limb, allowing more to reach the distal part of the tubule and collecting duct where it holds on the water. And then finally, another type of diuretic is mannitol. It's an osmotic diuretic. Osmotic diuretics, in order to be effective, there are certain rules that apply to them. They can't undergo any type of metabolism, absorption, or secretion within the kidney. In other words, when you give mannitol, it's given intravenously, and it's freely filtered. So mannitol is just a sugar, like glucose, except it doesn't get reabsorbed. So when it's filtered, it creates a solute load within the renal tubule that has osmotic pressure, that holds on to water, that opposes reabsorption of water. Okay? But it's starting not here within the ascending limb, it's affecting water that's been filtered early on within the PCT. So it's a very powerful diuretic. It's more powerful than a loop diuretic because it's blocking more of the tubule. Its activity begins in the PCT, not in the ascending limb. So before, when we said glucose acts like an osmotic diuretic, that's what I mean. If somebody has uncontrolled diabetes with severe hyperglycemia, they're freely filtering a large load of glucose, okay? That's going to overwhelm the capacity of the PCT to undergo reabsorption. And so it's going to act like mannitol. It's going to hold on to water and result in a diuresis. That's polyuria. All right. I'm going to put this last slide in here. Just kind of as a review. You know, usually I know when we look at slides like this, it kind of perturbs us a little bit. Like, what you going to put that thing in there for?
What are you talking about?
You know, but this is just an exercise where you can see, okay, what happens in our body when we lose volume?